from around the world from the ISRT Board of Management. Welcome to Facebook Live 6 today. Today is a very special day for the ISRT because we are featuring our very first online webinar where we're hosting our very own Dr. Napapong Dapong, who is actually our ISRT Vice President of the Australasia region. Now, Dr. Napapong comes quite equipped to talk about this subject because he has a very vast curriculum via on radiation protection. So today, Napapong will talk to us about patient dose monitoring and management in your clinical practice. Dr. Napapong is a PhD, an assistant professor and head of the Department of Radiologic Technology at the Faculty of Medical Technology at Mahalidal University in Bangkok, Thailand. He's also an adjunct senior lecturer in the Medical Imaging and Radiation Science School of Primary and Allied Healthcare, Faculty of Medicine, Nursing and Health Sciences at Monash University in Australia. He actually received his baccalaureate degree in radiologic technology in Thailand and holds a master's degree in medical physics in 1996. He attended the University of Texas Graduate School of Biomedical Sciences in San Antonio, Texas, where he received his doctoral degree in radiology medical physics in 2002. Napapong's professional experience actually includes physics measurements in radiology, MRI, operational health physics, and radiography education. Now, Napapong has been involved for a long time in our international organization, and he's done a lot of work with the IAEA as an expert in international and regional projects. He's also represented the ISRT on radiation protection with the World Health Organizations over the last couple of years. He holds a dual professional qualifications as a licensed professional radiographer and a medical physicist. He's also currently the president of the Radiological Technologist Professional Board in the Kingdom of Thailand. We're very excited to have him with us today, and I'm going to turn over the presentation to Dr. Napapong, where he'll talk to us today about patient dose monitoring and the management of clinical practice. Welcome, Napa.
Hello, thank you so much for your kind introduction, and very good morning, America, good afternoon, Europe, Africa, and good evening, Asia and Australasia. The topic that I will talk today will be patient dose monitoring and management in clinical practice. The content of my talk will include why we need to measure and monitor the dose, which means in this case radiation dose, and why we focus on high dose modalities such as computer tomography and interventional radiology. Then when we want to start doing this dose monitoring, how do we start? And then I will cover about the benefit of this dose monitoring, and at the end I will pinpoint about the role of radiographers in patient dose monitoring. This figure came from the previous Unscare report. We are still waiting for the official report for 2020 with the data from 2018. The last one was 10 years ago, but still we saw a lot of information in this report, including the global increase of the use of radiation. You might have thought about the high-dose procedure like nuclear medicine and radiation therapy, but in reality, the world population were exposed more frequently and result in population dose in diagnostic imaging that was about close to 4 billion procedures a year. Back in 2012, we had a very big meeting about this radiation protection in Bonn, in Germany, and all radiation staff and professions, we came out with this Bonn call for action that will set the scene for radiation protection in the next 10 years. That means from 2012 to 2022, and it's almost close to the cycle, but in fact ISRT has involved in this activity, and we already created a lot of activities that showing that the radiographer as profession, we are responsible for radiation protection. If you look at action one is very important. We talk about enhance the implementation of principle of justification. Justification means benefit outweigh the risks. That means when you want the patient to have the radiation imaging for investigation, you need to be sure that the patient get benefit, right? So actually the role of justification falls in to the radiologist as a major role in justification, but radiographers, we have proof that we do have role in the supplementary role for the radiologist, as the patients will come to see us first. All right, and after the examination is justified, then we move forward to the second action, that is the enhanced implementation of the principle of optimization of protection and safety. So my talk today will be mainly focused on this optimization, and I will go into to the details later. And other actions from action 3 to action 10 would include strengthen manufacturer role in contributing to overall safety regime. That's why in these days we see when we practice, we see those index showing on the monitor after we export the patient. And action 4, strengthening radiation protection education and training of health profession. That is what we are doing right now. Action 5, shape and promote strategic research agenda for radiation protection in medicine. ISRT has put quite a number of investment in this research funding for the radiation protection subject during the past years, and you already have seen that, I believe. And action 6, increase availability of improved global information on medical exposures and occupational exposure in medicine. Action 7, improve prevention of medical radiation incidents and accidents. The talk today will cover this action also, especially in interventional radiology. And action number 8, strengthen radiation safety culture in healthcare. We as radiography profession, we involved in this, and World Health Organization, they are very active in this safety culture in terms of strengthening radiation safety culture, and as radiographers we involve. Number 9, foster and improve radiation benefit risk dialogue. How would you communicate the risk with the patient? And action number 10, strengthening the implementation of safety requirement globally. As global organization, ISRT keep in mind always that as the profession, we are actively involved in all these activities, and we already publicize a lot of activities that we have done so far. Back to the international framework of radiation protection of medical exposure, we have justification, right? Benefits outweigh the risks, and after the examination is justified, then we go forward to optimization. And then the use of those limits is not applicable, as we know that medical exposure has no limit. We cannot say that, oh, we are working with x-rays, our annual limit is 20 millisievert. That means you cannot receive, as the patient cannot receive the dose more than us, which means 20 millisievert. That is not true. Medical exposure has no limit, but the way to protect the patient is include justification and optimization. The international basic safety standard by the International Atomic Energy Agency, the IAEA, is the foundation for all IAEA or United Nations member states, so that they have the regulation based on this basic safety standard. And inside the basic safety standard, they categorize 3 exposure situations, and these 3 categories of exposure include occupational exposure, that us, the radiographers, radiologists, and medical exposure that belongs to the patient. There's no limit. We have justification on optimization, and then public exposure, meaning people in general public, we have to make sure that they don't receive too much radiation dose when they come to the radiation facility. In terms of planned exposure situation that we focus on, I mentioned a couple of times already, fundamental principle of radiation protection would include justification. Justification means net benefit would exceed radiation detriment or harm, and only justified practice to be authorized, right? And then we talk a lot about non-medical exposure, like we do image for legal evidence, insurance, employment, immigration purpose, and we need to justify those also. So responsibility for justification decision mainly belong to radiologists, but radiographers as frontliners, we meet the patient first, we see the request first, we do justification also. So input to this decision of justification, radiation protection is part of the broader decision process. For example, when we get the patient referred to do CT, and then if we think, or the radiologist think that the answer to what referral physician want to know, we can do ultrasound instead. That means if we go further to do ultrasound, we save or we protect the radiation from exposing to ionizing radiation 100%, right? After the exam is justified, we will move forward to optimization process. What does it mean by optimization? Optimize means we constrain for risk and dose. Sometimes optimization does not always mean you reduce the dose. Sometimes optimization can be possible that we have to increase the dose if we have to. So responsibility for setting the dose constraint belong to the multidisciplinary that work together, mainly radiologists, radiographers, and medical physicists. And the third category of radiation protection activity goes to dose limitation. For example, we have the dose limit for lens of eyes, things like that. There's going to be 2 types of radiation health effect that we will focus on the talk today. I would want you to understand that types of effect. First one is cell death, that is deterministic effect. The dose would be high dose, right? High enough to cause the damage. In imaging and interventional radiology, maximum worst case scenario that we would see include skin reaction, and sometimes we have epilation or hair loss, and that's it. And the minimum dose to cause absorbed dose to cause that skin reaction is about 2 gray or 2000 milligray. That is a lot. When we just do plain film imaging, plain radiography, the skin dose is gonna be 1 digit, like 1 milligray, 5 milligray, 3 milligray, or maybe even less than 1 milligray. So we are not gonna see any skin damage or skin reaction when we do plain radiography, but in fluoroscopy we see a lot of those. But what else we see on top of this deterministic effect is the stochastic effect. That means we have cell transformation, right? So stochastic effect, in this sense, we focus mainly on cancer risks, right? And then it can be both cell death and cell transformation. On the left hand side is from the IAEA. Since 2012, I believe I was in that meeting representing radiographers. The IAEA called in representative from the main profession that working with medical radiation, including radiologists, radiographer, and medical physicists. ISRT sent me to this meeting at that time, and also they involved the FDA, the Food and Drug demonstration. What we had done at that time was that we issued a joint position statement on patient dose exposure tracking. From that time, we agreed that we need to monitor the radiation dose that the patient receives, and then the vendor give a good response to this joint position statement. So if you look at the radiology equipment these days, you will see that most of the equipment, they will come up with the dose matrix showing how much dose that the patient gets. I will talk about this in detail later. And then Madan Rehani, Dr. Madan Rehani, our good friend to ISRT, he did a lot of research. Back then, he's working at the IAEA. One of the research topic was published on the Lancet, was about tracking radiation exposure of patient, because in the old days we have not seen anything like skin reaction or epilation in CT. But when we start to do CT perfusion means you keep exposing the same volume of brain tissue at the same time, and then you inject the contrast media to see the uptake of the contrast media that shows the blood flow to perfusion, but perfusion to the brain tissue. That means you expose the same area with a certain large amount of radiation. We start to see some skin reaction. That was quite alarming back then. And if you look into the other side of radiation effect, we have deterministic effect, right? Skin reaction, epilation. Another side is the cancerous. If you look at this graph from Brenner, he has done a lot of research in radiation biology, and in this publication back a long time ago in 2007, you can see that organ dose and cancer risk from CT. If you look at head CT and abdominal CT and plot against the age at time of the CT study, you can see that at children age, you see much more risk of cancer than the adult group. And if you look at CT, and then you know that CT, the patient has a lot of burden to radiation dose, and a lot of news coming out, especially in the US. And then on the left hand side, they talk about CT overdose. We heard a lot of this. And then the left hand side, and on the right hand side, this was the very first case that the patient sued the hospital about not telling the patient that after fluoroscopic procedure he might have got some skin reaction, and that gave the alarm to the radiological community like us. If you look at typical effective dose from interventional radiology, effective dose related to stochastic risk or cancer risk. If you look at the IR, interventional radiology, you can see effective dose from, like, if you do head and neck angiography, just plain diagnostic angiography, the dose is about 5 millisievert. But if you look at the interventional procedure like pelvic vein embolization, down at the bottom of the table, you can see that the dose is quite high. It's about 60 millisievert. It's quite alarming high. And if you look at the potential skew effect that I mentioned before, the minimum dose that can set the skin effect is about 2 gray or 2000 milligrays. That was early transient erythema, like the skin reaction, and main erythema start at 6 gray or 6000 milligray. Temporary epilation start at 3 grays or 3000 grays, and permanent epilation start at 7 gray or 7000 milligray. But roughly, when we talk about interventional procedure, we are unlikely to go up to 6 or 7. But in some case, we might have seen that. It's from my experience when we start doing dose monitoring. The point that we have to look at and have to keep in mind is that after the patient get exposed to this fluoroscopic investigation or procedures in interventional radiology, the skin reaction, we know that the threshold dose is about 2 gray or 2000 milligray. But the point is, we will not see the skin reaction right away. So there is something called the onset of the skin reaction. It can be weeks. So the point is, if you are interventional radiology radiographers, it's your job to help monitoring, right? When we see those kind of parameters, we have to set up the protocol. When do we alarm the interventionist? So tell the doctor that if the patient come back for investigation or come back to see that doctor, they have to look at the skin reaction that might happen. I will show you later what are we doing at the moment. A lot of people ask, even back home in Thailand, we started radiology back 90 years ago when one radiologist came back from the US and then start a radiology service in Thailand. And we talk about during the past 90 years, we never bothered to measure the dose or monitor the dose. We can practice, but why we measure the dose or monitoring the dose now? There are two main reasons on the red color. First one is regulatory requirement, the law. Basically, this regulatory requirement depends on the area that we practice. In Europe, the Euratom and the regulation in Europe clearly says that you need to monitor the dose. But in the US and I think most part of Asia and other part of the world, we do not have this regulation that we need to monitor the dose, but we follow the accreditation requirement. A lot of us follow the Joint Commission International, JCI. This is part of that requirement, so we do through the accreditation. Another reason of monitoring the dose would include liability, public relations, research, QA, awareness and patient safety. And this issue is coming out very popular that we are talking about at the moment is individual patient cumulative dose record. You want to see a single patient, how much he or she has been exposed during the past year, something like that. So we have to accumulate the number of doses that a person has already exposed. If you look into the detail at the Joint Commission, there are two things. Joint Commission is back in the US, the main Joint Commission, the original one, and international version we call JCI, Joint Commission International. Basically, the JCI, the international version, just follow probably one version as compared to the original Joint Commission in the US. And the current Joint Commission in the US already said about CT. What you need to do to be certified by this JC or Joint Commission is that you need to restructure of radiation safety initiative, enhance current practice around several points. What they focus on include CT protocol. You need to review CT protocol. There are two sentences. First, one size does not fit all. That means you can't use adult protocol with the pediatrics. And then children are not small adult. See, one size does not fit all. When you expose the patient with adult patient or pediatric patient, you use different protocol. And patient with different sizes or weight, you adjust the protocol or the dose also. They will look at this. And then you need to develop the incident management policy and procedures. A lot of things like contrast, injection, or the adverse effect of the contrast, or sometimes you look at the right person or not you expose, or the right side, the right person, patient identification, things like that. And then what JCI requires is that you need to buy or procure the technology, the software to track and monitor the radiation dose. But international version at the moment, it does not require, but the JCI require you to know the dose that you expose to the patient. And then another issue is that you need to revise the general workflow and daily practices for performing radiology exam. And as of January 1st last year, there are 5 new Joint Commission elements of performance focused on fluoroscopy. In my talk, I talk about 2 modalities that give high dose, including CT and interventional radiology. In terms of interventional radiology, what you need to do to comply with the Joint Commission requirement is that the equipment needs to be checked to ensure that fluoroscopy unit is working properly, and then you need a standard staff education for your physician who run the fluoroscopic exam on radiation dose management and equipment operation. And then you need to designate the Radiation Safety Officer, the RSO, to provide oversight of the radiologic services. And you need to capture radiation dose information. You see, capture dose information. And then this is important in most of the practice that we need to start is to establish the radiation dose threshold that warrant investigation. Says if the skin reaction started 2 grades, then if the patient those data shows that the skin in any patch of skin reach that amount, then you need to inform the doctor or interventional radiologist. Here are signs that you may not be prepared to get accredited. First, if you don't have organizational radiation safety committee, mostly this is easy. You just have the hospital director assign the committee. Basically, the chair is the radiologist, and then we have the manager from radiographer. Sometimes if you have physicists on site, there will be one of them. And radiology exam needs to be performed by registered or licensed technologists. In a lot of places, this is the law. In my country, if you are not certified or you are not licensed in your practice, you would be subject to two years jail term. You will be in jail for 2 years if you do that. And then the sign that you may not be prepared include that you cannot track the patient radiation dose. This is also important. And then they will also look at the outdated and substandard CT protocol that you use in your facility. Also, you need to have policies or procedures regarding radiation dose tracking or incidence management. Before going to how do we do it, I would like to talk about patient dose matrix. There are 2 metrics. The first one is dose. Dose we need to measure. Dose mean organ dose, equivalent dose, effective dose. We need to measure or we need to calculate. But there are another type of dose we call dose surrogates. Those surrogates, for example, cumulative exposure time, entrance air curve, dose area product, cumulative dose, peak skin dose, CTDI, dose length product, and SSDE, site-specific dose estimate. These parameters mainly come from the DICOM header, and it's normally shown on your monitor console. These are dose surrogate. It's already available and it shows how much dose to expose to your patient depending on the modality that you practice. There is a tool to help you we call dedicated dose tracking software. Basically, this software would integrate the dose matrix from imaging system or PACS. A typical format include DICOM. DICOM standard. And, most of the dose metrics are from the DICOM header. And then for radiation dose tracking system, we have another format we call RDSR, Radiation Dose Structured Report. In this system, especially in interventional radiology, if you want to know what angle that the tube point to the patient, things like that, you need RDSR to help you calculate the skin dose. And this software mainly integrate with PACS, RS, or EMR. It has analysis capability. You can select of reference dose so that you can monitor, you can quantify the dose, and you can give alarming to the staff about high dose that happen to your facility. And it has also automated notification. For example, if we set up the automated notification in CT, for example, if the dose, for example, CTDR exceed 50 in this examination, then a person involved or the person responsible for the dose monitoring will be notified automatically by email. Then when you click on email, say this patient received too high CTDI volume, when I click it, and I will see if the patient is standard size patient, then we need to look into it, what happened. But if the patient is overweight, then we know, okay, the patient is overweight, it's normal that the dose is too high, things like that. Here are example of dedicated dose tracking system. This is worldwide now. Numbers of vendors they are marketing this include Dose Monitor from Pack Health, Sectra has Dose Track, GE has Dose Watch, Siemens has Team Play, and Bayer has Radimatrix. If you ask me what's the difference, pretty much they are quite the same in terms of capability, in terms of dose tracking, and in terms of analysis. But there are some differences in a way how would they link the system to your packs or your modality. In clinical practice, when we talk about dose monitoring in clinical practice, the first thing is I always talk to my radiologists, my radiographers, and also the physicists that I train. First, you never know how much dose your patient received during the scan unless you measure it or you monitor it, right? In radiation therapy, normally radiation oncologist will prescribe the dose, how much dose he wants to expose to the cancer tumor. But in imaging, referral physician never ever asks. They normally ask, well, we do CT whole abdomen. They never ask CT whole abdomen with 7 milligram dose, right? It just refer or request the exam without the dose. The dose we have to measure or monitor it, and the dose values can be used for optimization. In diagnostic radiology, we do not measure the dose, just we want to know the dose. For example, when you do CT scan of the abdomen, do you want to know how much the liver receive, the dose that the liver receive, or do you want to know how much the kidney receive in terms of dose? No, it doesn't make sense. It doesn't mean much. Well, we can calculate it, we can monitor it using the software, but the point is the dose values that we receive, the dose value that we monitor, it is used for optimization. That means the dose is too high or too low. My point is, the lowest dose doesn't mean it is good, because low dose will harm the image quality. Optimization means you have to balance between image quality and dose. And in diagnostic imaging, the dose matrix we use is for optimization. Alright, and then in clinical practice, we also do monitoring to comply with the Joint Commission. And then a lot of places we talk about setup, compare your dose with the DRLs. In many countries now, you have your own DRLs, and this, if you collect your own data, you can use these data to compare with DRL so that you can do optimization. In general, there are common features of dose monitoring software. The first group is basic homemade software. I have my radiography student doing this software. It's not that difficult. They can just extract the DICOM dose data from DICOM, and then they can just put it out, and then they can display how much dose the patient get based on this. But the limitation of the basic or homemade software is that the analysis capability is limited. And basic commercial software means like it has a DICOM or the RDSR format, but with limited analytic capability. Those cheap one or the free to download are available. And then we have advanced commercial software, and this software has large number of mathematical phantoms. what do they mean, mathematical phantom? So when we want to calculate the dose, one way is to do direct measurement, which is difficult to do, right? If you want, well, of course you can do it. If you want to do if you do abdomen scan, CT scan, and if you want to know how much liver get in terms of radiation dose, of course, you can just operate the patient, put the TLD chip inside the liver, and then close the patient and expose the patient and open up again, pull out the TLD rod. It doesn't make sense, right? So the thing is, we can use mathematical phantom. Mathematical phantom means like we have the mathematical model to simulate different sizes of the patient, of human, from fetus, from children, and from adult, male or female, and then we just use the software to simulate how much x-rays that we expose to the patient, what kind of interaction that happened, and how much dose deposit to different part of the body. That means these mathematical phantom. The method that we use is called Monte Carlo simulation, and these advanced commercial software normally has the advanced analysis package. I will show you later. And let's first take a look at this DICOM tag. Right? If you learn digital imaging and PACS, you must know this DICOM tag. This is pretty much standard platform that we teach the radiography student these days in terms of digital imaging and PACS. They need to understand this DICOM. The tag number, for example, 0010, comma 0010, that is patient's name. And if you look at the right hand side, the tag number, say 0018, comma 0060, that's KVP. And what about the dose matrix? Look at the last one, the DLP. The tag number is 0040, comma 0310, that's the dose length product. In the commercial software, this is the radiomatrix that we use in my hospital. In each examination, we see these data. We see CTDI volume, we see the CTDI depends on the phantom or the investigation. Normally there are two types of phantom that include 16 centimeters for the head and 32 centimeters for the body, and then we look at the CTDI volume just to compare if the technique that we expose to the patient is optimized or not. But in reality, the patient dose is DLP, dose length product. Dose length product is equal to CTDI volume multiplied by the scan volume. All right, this is CT. In general, these figures we can directly extract from the DICOM header. But if you want to look at more precise calculation of the dose to individual patient, since the dose from DICOM that you can see from the CT dose sheet mainly phantom dosimetry, not patient dosimetry. As I said, there are two sizes of phantom, PMMA phantom 16 and 32. Mainly each year physicists will come and do the measurements for the CTDI. But the head is not that big problem because normally head size not vary so much. But for the body size, 32 centimeters of the phantom may not fit all sizes of the patient we have. So we have smaller size than 32 centimeter and we have larger sizes than 32 centimeters. Then we have to adjust so that we get more accurate dose that that individual patient get. We call SSDE, size specific dose estimate. Basically these come from the axial scan. We just calculate based on the length of the size of the image that we do measurement. I mentioned before that we look a lot at the organ dose and cumulative dose when in numbers of facilities, especially when we look at the cumulative dose. For example, if myself during the past year I was exposed doing chest x-ray, KUV x-ray, CT brain, CT abdomen, and if I went to the same hospital with the same identification number, my cumulative dose will show up here. Normally the cumulative dose, since different modalities, CT, plain radiography, mammography, the dose matrix would be difficult or different, not difficult, it's different. So when we want to compare or we want to harmonize unit, we convert into effective dose. So cumulative dose in practice now, what we are doing is that once the cumulative dose of a single person reach 100 millisievert, which is quite a lot, then you have to go back to do justification again, if it is justified or not, really justified or not to do more CT scan or other X-ray investigation. But normally the patient that would get dose more than 100 milligrams, mainly the cancer patient, then well, I can't say it doesn't matter. I say, how do we optimize? Sometimes, well, justification is there because the patient needs diagnostic information for the treatment, right? So cumulative dose, this is important. And some software, they have the interactive dosimetry for the technologies of radiographers. Also, we can play around, say, if we change slide thickness, if we change the pitch, change the kV and MA, what kind of dose the patient would get in each protocol. And for DRL, diagnostic reference level, we can set up, there are different types of DRL. We have national DRL, and we have like regional DRL, and we can even have the institutional DRL if we are big enough. But the point is, if you have your national DRL is the plot of those metrics. For example, in this case, if we plot SSD, site-specific dose estimate, or we plot CT dye volume, so we plot from the lowest figures up to the highest figure. DRL is the 75 percentile, or the point that is 75% highest. That's the DRL. If you want to compare your hospital, your institutional DRL to the national DRL, you do not use 75 percentile. It's not right because the statistics is not there. What you do is you use your median or 50 percentile to compare. If you practice in a hospital, say if you want to compare your abdomen protocol dose in terms of CT dye volume, for example, with your national DRL, you use your 50 percentile, not the 75 percentile. This is the example we just plot effective dose, CT dye volume, GLP, and breast dose from this abdomen protocol. The dose software can display this, can analyze for you. And switch to fluoroscopy and interventional radiology. There are different things that we look at. In imaging, we focus on the stochastic effect, right? The cancer risk. But in fluoroscopy, interventional radiology, we also focus on deterministic effect, which is the skin reaction. Likely when you use this dose monitoring software, what you can get is include peak skin dose, fluoroscopic time, DAB, dose area product, and reference point dose. I'm not going to go through all the details because we need 1 hour to do. I will maybe in the future we just set up another webinar on different modality, how do we monitor the dose. But in fact, what we can do on top of the cancer risks, which we use that dose area product in fluoroscopy to convert to effective dose to quantify the risk, we also need to quantify the skin dose because we want to look at possibility of the skin reaction. This is the protocol. I believe this is from MD Anderson Cancer Center in Texas. They have the patient follow-up for high dose. What they use is the peak skin dose. If it's larger than 3 grays, then you have to notify the technologists or radiographer need to notify the interventionist, right? Those indicators should be recorded in the patient record, and normally skin reaction will occur about 2 weeks after exposure. So when the patient come back for follow-up, the interventionist would know he or she need to look at the skin patch that has the possibility of the of the skin reaction also. In this case, example in cardiology, in cardiac intervention, right, in cardiac catheterization lab, normally cardiologists, they have this 369 rule. What does it mean, 369 rule? If you look at the photo on the left hand side, well, we are not likely to see this in the practice, because if the skin reaction is as bad as this, the dose would be like up to 7, 8, 9 grades. That's way too much. But the point is, the 369 rule give the warning to the physician. For example, at the first warning at 3 gray or 3000 milligray, the physician is alerted. This is the first alert for the physician information. Why? Because this patient is not like it can be possible that the patient come back to get another procedures, right, to fix something else. So if the patient come back, the physician would know that skin patch already has 3 grays. So what the physician or the interventionist needs to do is, he or she need to reorient the radiation beam direction so that the skin dose at that patch would be preserved, not too high, right? Change the direction so that the skin dose burden would be in better shape, right? And at 6 gray, 6000 milligray, physician is alerted. What does it mean by this? We warn the physician the risk of erythema or more severe effect if the beam direction is not changed. This is important. And if it's not at 9 gray, this is very rare case. The degree of risk depends on if the beam direction can be diverted or not. Then you need to talk about those risk-benefit decision. Will a patient come in to get cardiac cath or to get interventional radiology to fix something, like fix aneurysm or something else? Justification is there already. You just cannot let the patient get worse. You need to fix something, and then you have to weigh between radiation burden that the patient get, right, and then the benefit if the patient has to go further for the examination. The thing is, if we monitor the dose, we know how much dose that the skin patch already received. If the patient has to come back, then the physician would know he or she need to re-angle or angle the X-ray tube at different directions so that the dose won't be added too much into the same region, right? That's the thing. So in fluoroscopy, we do monitor for 2 things. First is stochastic risk. We monitor dose area product. And we monitor deterministic risk or skin reaction, so we monitor the skin dose. All right. And here are lists of procedures with potentially high dose and possible skin reaction. Here are the list. And this case we see a lot. This is the real case. I got consult. I also practice as medical physicist on top of radiographer. This case was sent by my radiography student. She graduated already. She just, I don't know, people always text me something for ask for something, and then she asked like, hey, she just texts me, teacher, something happened, and something like what, and then she texts me, she sent me this photo, like she cropped the image from the console and said, oh my god, look at that. So we cannot say beautiful, but it actually is beautiful. Look at the fetus in there. So this means she exposed the fetus. So when we see this case of emergency, if the physicist has to calculate this, we have to fit a lot into the model, or we need to know a lot of dosimetric data. But with the software that we have, the mathematical phantom would fit in. Normally, when we calculate the dose, we would pick up the gestational period, right? The the trimester, and then fit the size of the patient, the depth of the fetus, and the position of the fetus, and then the software would calculate for you. What you look at is the fetus dose is the dose to the uterus of the fetus, and then you get the amount of dose that you want to report to radiologists or referral physicians for further management. If you have this software, it's easy. I'm not here to sell the software, but I'm telling you, it helps you a lot. On top of this, what do we use this dose monitoring or tracking software for? In the US, they have American College of Radiology Dose Index Registry. I know that another country are doing the same thing. Japan started already. In Thailand, we also got the grant from the IAE. About the first grant is about 300,000 euros, and I'm responsible for this. We're gonna set up something like this, the ACR Dose Index Registry. What it means is the hospital will send the dose data to the ACR head office with this center, so that the dose data will be come in to the centralized unit, and then the dose will be analyzed, and what the facility would get is the benchmark, right? When you send the dose data, the system will filter out the patient identification, right? They will not send the patient ID, name, sex, whatever, but just the only dose metrics, the CT dye volume and DLP. And here are lists of software that are compatible with this ACR Dose Index Registry. So benefit of this dose monitoring would include benchmarking your dose. As I mentioned before, if you don't quantify the dose, if you don't monitor, if you don't measure, you won't know how much dose you expose to your patient. And then if you go through this scheme, you know your benchmark means how much dose you expose to your patient, say whole abdomen CT. When you want to compare with your national data or your regional data or international data, you get your benchmark. Say if you expose too much dose or too small dose, too high or too low, both are not good. Too high means the patient get too high dose, but image quality is very good. But if the dose is way too low, you have to investigate on that also, because that means image quality is very poor. Sometimes radiologists will miss to see the pathology, right? And the second benefit is the best practice in optimization. As I mentioned many times, those will give you idea for optimization. And last but not least is about protocol management. How much you want to adjust the protocol, how do you want to do the scan. This is the paper published by the ACR Dose Index Registry by Dr. Kalpana. Her group collected the data from this dose index registry, more than 1 million examinations. That's a huge data. The title is US Diagnostic Reference Level and Achievable Dose for 10 Adult CT Examination. The point is, when you do DRL, you only do DRL means dose matrix for standard dose matrix for modality, dose for standard size person. In Thailand, we use 60 kg plus minus 15 kg. That's our size. But when we want to compare, our population size may not be able to compare with larger size population like the Europeans or the American. So DRL means standard size patient, right? And standard examination, that means you pick up like common examination that you want to set your DRL. And this paper gives you a very good benchmarking in terms of how would you collect the data, how would you classify the protocol, things like that. I'm not going to go through too much details on this, but the good thing is, on top of the DRL, you also get your achievable dose too, right? Like the maximum dose that you can go, and what is achievable, like the dose that you're supposed to give to your patient, to expose to your patient. And this is from my experience. This is from one of my center that I take care of. If you look at this figure, you see that from one hospital we have four CT scanners, head protocol, head CT. And if you look at the dose, there are 4 towers. What does it mean? I mentioned before the head size won't be too much different, right? And if you come from the same population, like same Thai people, your head won't be big difference. But why we have 4 towers? That means we expose 1 CT, first CT, second, third, and fourth CT. We don't give the same dose. Why? If we don't investigate, if we don't monitor, we won't know. And if the first thing I saw this, I talked to my radiologist. Let's do something about this. Okay, because it can't be like this. It should be in similar values. And if you look at abdomen protocol, wow, that's big difference in there, right? From way too low and way too high. When you first look at your dose data, you will start thinking about what to do, and this dose monitoring is not a job of physicists alone. It's not a job of radiologists alone. It's not a job of radiographers alone. It's multidisciplinary approach. We work together. When you look at, now stop with CT, now we move to interventional radiology. We want to look at the dose reference or diagnostic reference level also. I would rather say dose reference level because IR is more treatment. But in IR is different because it's quite a challenge to implement because patient dose depend on wide variety factors, difficulty to do, degree of difficulty to perform each examination, and DRL should be assessed and used as a tool for optimization for interventional procedures. Like normally we use DAPT or dose array product for the dose, and DRL quantities should be tracked for interventional procedures, and this will aid the optimization process, right? Optimization is the key, and complexity is determinant of patient dose and should ideally be evaluated individual for each case, as I mentioned. Degree of difficulty to perform different examination would be vary a lot in terms of interventional radiology, but sometimes some centers they have the multiplying factors for the DRL, means like very easy case, fair case, difficult and very difficult case, something like that, because the dose won't be the same. The difficult case, the doctor has to perform long time until he or she can finish the procedures. Normally, in the old days, before the time of dose matrix, we only can collect the data for cumulative fluoroscopic exposure time. This is very bad for DRL. I would suggest that if you have a new machine within like these 10 years, I think most of them has this dose matrix come out. But the funny thing is, when I work with a lot of numbers of the hospital. The thing is, in a lot of place, dose matrix is there, but it doesn't show on the monitor because the service engineer did not enable this option. So when we first want to monitor, we have to take a look if your modality has the option or not. If your modality has the option, you have to show it. Right? And if the DRL quantities for the patient are higher than expected, investigation should start. Right? If normal people around the world, the same investigation, the same procedure, say we use 100 DAP, dose array product, and your facility use 150, then you have to think about, do you use 2O machine? Has the machine been checked by the physicist? And what is procedure protocol is like? And finally, operator technique. Do you do the same as others? Then you have to compare. I always say it, when you compare, you have to compare apple to apple, banana to banana. You have to compare the same thing. Here are a good publication, most recent publication about interventional radiology dose. One from Europe, from France, the French data, and also from the US data. I will upload the PowerPoint slide on the website later, so you can have it. And here are the good thing is, if you have this example when you monitor, because there are a lot of protocols or there are a lot of procedures that you do in IR, you can just duplicate this they are pretty much the same. This is the US data, and this is the French data. Like they categorize as cerebral angiogram, just the imaging, spinal angiogram, and then they have something like treatment protocol also. We always say monitoring radiation leads to quality improvement. It's not going to give you money. It gives you quality improvement, right? Quality improvement, validation of your DRL, and at the end, the benefit will go to the patient because you have optimization of radiation. And also, a lot of this software has the function of monitoring the contrast media dose too, how much you inject to the patient. Back to the registry. When we look at the benefit of the dose registry, what do you get? That's a cycle, right? We have cyclic data-driven improvement process. First, facilities submit radiation dose data. And then normally we get quarter report back to the facility about how much dose they expose to the patient in the same protocol compared to other facility, like analyze the result and develop and implement improvement plan later. At the end, we get the optimization. The tricky thing is that to standardize the protocol, I'm not talking about this in this lecture, but in the future lecture, we may go into the detail. The thing is, like when we talk about CT scan, brain scan in one place may be not the same as the brain scan in other place, or the whole abdomen or abdomen pelvis. So when you want to compare, you have to compare apple to apple. What you need to do first is grouping the protocol. And there are standards out there we call LATLAX from the Radiological Society of North America. A lot of press using their approach. So in this cyclic data-driven improvement, we show that this is from UK data. Back in 1980, 50% dose reduction when you monitor it, and in 1990s it's 20% reduction. That's the good thing. If you look at the graph, the dose registry result, you can say like in your present, when you get the benchmarking result, you get something like how much you exposed, in this case CTDI volume. When you compare to national data, UK data, Portugal data, ACR dose index registry, or the state data, then you can see your benchmark. What you see is, if you say your dose is way too high, then you have to optimize. And if you say your dose is way too low, you have to look at your image quality. Alright? And before we finish this talk for today, I would like to emphasize about the role of radiographers in dose monitoring. Our practice varies from one place to another. In many places, technologists has a very unique role, like in East Asia, like in Japan, to take care of the dose of the patient, monitoring dose management also, but in some other place you may not. So, but the point is, in global perspective, we look at team approach. We work closely with the radiologists and the medical physicists because we are the radiographers, we are the one who contact the patient and know the dose data first. When you do CT scan, you see the dose data first, CTI volume and DLP. That's what you see. That's you see first. And radiographers has clear role in dose optimization because we expose the patient, we control the dose. We have this degree of autonomy in our profession to control the dose. That's very, very important role. That's why we need to know and learn about dose metrics, right? And radiographers also have role in CT scanning protocol management. Right? Say we work closely with radiologists. Do we really have to do 4 phases abdomen protocol, 3 phases or 2 phases with the same scan volume in all protocol? No, we have indication-based protocol, and then we discuss with the radiologist how to perform the scan so that the dose reduction is there. We have also a degree of autonomy in this, and this is clear role about protocol management that radiographers have. And last but not least, knowing the dose will lead to optimization, and at the end we benefit to our patient safety. That's the key. In summary, dose monitoring is a tool for optimization. I always mention, I always say, dose monitoring or dose management is doesn't mean you measure the dose. That say abdomen scan, you don't do measurement how much dose liver get, things like that. But we do monitor or measure the dose matrix that shows that in imaging procedure you expose the patient too high or too low dose, things like that. That's for optimization. And DRL, diagnostic dose reference level, should only be used as quality improvement tool. You can't just say, oh, we have DRL, our dose do not exceed DRL in all the patient. No. When you compare the DRL again, national DRL, when you compare your facility, you do the median because you want to have the data that represent in general patient that you have, the patient population that you have, because DRL means for standardized patient, common examination, things like that. And those registry would help facilitate the development of DRLs and provide benchmarking. And this has been successful back in the US. I know Japan started this already, and Thailand we start actually this month. We just start this process, and the dose reporting and optimization has led to lower patient dose exposure, and this has been proof. All right, these are what I want to talk for today, and if you have any questions or comment, I'm happy to answer those questions. And thank you so much for your attention.
Dr. Napapong, I can't thank you for this information you've given us. I have been watching the questions coming in, and we have some really great specific questions and some general questions. But before we start with the questions that came from the Facebook Live, does anybody from our Zoom meeting have a question for Dr. Napapong? If you do, just unmute your microphone and ask the question. Well, we will move to our Facebook online questions. I want to let everybody know this new webinar that we are doing. We're giving people an opportunity to sign up and get a certificate of participation for a limited number of seats for those countries that need that certificate for their countries. And then for anybody else that's interested in learning and watching, they can just go on the Facebook Live. But we had some really great questions. So Napa, I want to start with this question that came from the audience regarding dose monitoring to the patient. What do you think the role of the regulatory agency should be in dose monitoring?
I think it depends on how would your country want to do. For example, like in some places like in Europe, there's a law, I believe, but in the US and part of Asia, it's more on accreditation. So it just depends. But at the end, even we don't have the regulation, you use accreditation flow with the way you do.
That sounds great. Also, very interesting. They talk answering.
Yes, we do, because we can't the train to risk and I radiologist here in Thailand, Royal to follow the radio to days if the patient we have geography perfect. One of the risk communication.
Now, a member of a asked
Like I'm U.S. public decides here's the scan. You scan, and if you want to figure that you if patient is not like the phantom in the scan. The thing is, here out it on the our health, and that's the thing that we
by
those math. Even you call different words for those when we
a general.
you you actually can do it, man. We can't force everyone. But the thing is, when before the time, what you do is sampling. You can do it, man.
How to determine if the procedure should be done or not? How do radiographers roll in that? Determining that. What do you suggest?
So in terms of pregnancy and medical radiation, there are two case scenarios. First one is we know that the patient is pregnant already, and the second scenario that we don't know by the time of exposure. So if we know the patient is pregnant already, then it needs to go through the justification. The referral physician together with radiologist will discuss what to do, and if it is justified that they do it, with limitations, say with less phase, less coverage, and the symmetry needs to be calculated and be ready by the physicist. Physicists will come in for the dosimetry evaluation. what radiographers do is we provide information to these colleagues. For example, how do we scan? And in the second scenario, if the patient came in and did the CT already and she didn't know that she was pregnant at that time, and later on she know from the way they examine her. So if in this case scenario, radiographers, our duty is to provide the physicist all the technical parameters, the correct technical parameter. How did we scan the KVP and other parameters that we use? And then most of the time we have to send them the sample of the scout scan, like the coverage of the radiation.
That sounds great. Now, we received another interesting question that I wrote down that I thought would be something that you would be able to help give some insight on. Now, you talked about in your talk that standard staff should have education on dose management, physicians and all staff working in fluoroscopy. And what other modalities do you think this standard should be adopted in?
Basically, I think in most places, the three highest modality in imaging that we need to do dose monitoring includes computed tomography, nuclear medicine, and interventional radiology or cardiology. There are three modalities that we need to monitor because they are high dose modalities. That's common practice. But for like plain radiography, we can do monitoring, but we need to have the software because we have so huge amount of the patient coming in. We can't really monitor the dose for every single person. Basically, we do dose audit instead by sampling the exposure parameter of the standard size patient and then calculate the dose matrix and compare with the DRL.
That's great. Now, another question that came in from a global perspective, who do you think should sit on the committee to develop the radiation safety initiatives?
Well, stakeholders. We have done a lot of this with the World Health Organization and the IAEA. Of course, radiographers is part of the team. So basically, that will include radiologists, radiographers, the physicists, and other stakeholders involved. For example, the IT people, things like that.
Wonderful.
And as RSRT, we have to guarantee to our member that we always represent you very, very well.
Wonderful. Now, back to a more technical question on an adult CT brain perfusion. What CTDI volume or DLP reference should the scan cover, 40 millimeters or 80 millimeters? Now, does that make sense to you? Because it doesn't to me.
It does. It's depend on what you look at. So basically, what you need to do is you talk to your neuroradiologist about how to perform this, like the scan coverage, and then how much contrast you inject, and then how many phases, probably like pre and post contrast. But when you inject, you need to do some calculation by quantification of the contrast uptake into the brain tissue. So it depends on the protocol and the disease that you look at. And I think this is a good idea that a lot of places we do webinar on the technical side, because my talk is more like hybrid, because it's something radiographers have to do. We must know, but we are not doing this alone. But in terms of like we are the man is the technical part, the technical procedures that we perform. And I think that kind of webinar has to come out from the ISRT also.
Wonderful. Now, another question that came up is for the peak patient skin dose indicators that should be recorded in the patient records. Do you believe this should be like a hospital policy or just part of your protocol?
I think it should be a policy because in terms of accreditation, like JC and JC already said out clear that you have to do it. And in many places, they have the regulation or the accreditation requirement. So what you need to do is you have to have your institutional policy and procedures about this. And then you develop together with your colleague, with your physicist, with your interventionist on what to do. That's going to be something like a flow chart. Say patient come in, what parameter we need to look for. And if the dose is higher than the threshold that we set together, then radiographers who always there with the patient will inform the interventionist about the current situation and see how to further manage the case.
And then now to a more technical question again. What are the main reference parameters to measure for the dose CTDI volume or DLP?
See, for dosimetry, patient dose in CT is DLP, dose length product, because dose length product means you multiply CTDI volume, which is the dose that exposed to a slab of tissue from one collimation, multiplied by the length of the scan. So the absorbed dose to the patient. And normally in US, it's the requirement already that radiologists have to report the DLP, which is the dose that the patient get, total DLP during each scan. So to answer the question, DLP represents the dose of the patient that the patient received, and CTDI volume represent the technical aspect of the scan. So you can compare protocol to protocol. Say one hospital, you have this protocol coverage, and then a KVP of this KVP, this collimation, this pitch, and so on, this MA. That's gonna influence the CTI volume. Once you change the parameter and then you want to compare the image quality, then you compare the CTI volume. That's for technical comparison, not the patient dose.
Okay. And then I'm not sure if you're able to answer this question or not, but what is the dose reference for a CT adult or child or infant for CT protocol for a brain or body exam?
DRL, mainly we normally have 2 DRL, one for adult and one for pediatric. But pediatric is tricky because it can be from infant to 15 years old. So what they do is they typically do age banding, say 0 to 5, 5 to 10, things like that. Because the size vary a lot for pediatric cases.
Well, those were the questions that I recorded from our Facebook Live audience. I want to, I see we have a chat question here. This one is just saying thank you for the wonderful presentation, and I echo those results. Napa, I think that your presentation was fantastic. I want to just offer one more time to anybody that is on our Zoom meeting. If they have a question, please unmute your mic and feel free to ask it now if you have a question. Okay, I think that we have covered all of the questions that the Facebook Live audience have. I want to thank Dr. Napapong Dapong, our ISRT Vice President of Asia, Australasia, for presenting this expertise on patient dose monitoring and management and clinical practice. I want to encourage everybody to tune back in on August 30th, where we're going to have a talk show session from our 10-minute presentations from our different regions, talking about the radiographer's role in dose management and optimization, and see what our countries are doing specifically within our regions. And know that in the future, you will see these Facebook Live webinars where you have an opportunity to register and get a certificate if you need those for your country. Those are limited to a certain amount of seats. And then, of course, as always, we'll continue our Facebook Live sessions every 2 weeks. And know that if any of our members are interested in a particular subject, you can just message us or email us. We're happy to cover any pertinent issues that are affecting our radiographers around the world. We want to be your global voice, and ISRT is here for you, and looking forward to more opportunities to host these sessions. Again, thank you for your time, and have a wonderful morning, afternoon, or evening wherever you are around the world. Thank you very much.